Also happen if you're passing a catheter and the catheter passes the dura from the epidural space and you end up giving a drug in the wrong space. But what happens is there'll be of the drug. Typically, we shouldn't go on T4, but this time the drug will spread beyond T4 and T1. Those are the dermatomes that supply above our breasts. And hence, there's sudden loss of sensation, both for the motor and the sensory parts, where we end up seeing a lot of severe hypotension, a decrease in heart rate, patients start feeling nauseated and agitated, a lot of shortness in breath, and then suddenly, if we try to grasp with the two fingers, which is the small, the ring finger, and that really confirms that now we have a problem. For the total spinals, if you've given a drug and suddenly the drug passes now T1 and T4, it will end up now going to the brain and typically ends up in the brainstem where there is loss of sensation and both motor and sensory, sudden loss of consciousness. There's aggressive convulsions, which is normally tonic-clonic. There is cessation of the respiration and also cardiac cessation because of the brainstem innervation, but suddenly we see pupillary dilatation most of the time. These two incidents I've told you are used interchangeably. Most people, when they've had a total spinal, they think they've had a high spinal, but a high spinal is just simply we've blocked the nerve supply of the heart, which we call cardiac sympathectomy. That is T1 up to T4. And then also we end up blocking C3 to C5, which is the phrenic nerve, so the breathing becomes a challenge. And then also we block the T1 and T2, and then grasp becomes a challenge. So it is kind of gradual. The patient actually is able to talk to us of their concerns, and we really can also see the monitor that we are getting all these bradycardias because the heart cannot able to produce adrenaline anymore because you've blocked its supply from adrenaline. That's what happens. The incidents are very, very varying. Thailand reported an incident of about 22.4 when they did a retrospective study between 2029 and 2020. Netherlands found 1 out of 29,000. That means they are really doing very well. And that's what one person required in endotracheal intubation. And the same as the US, 1 in 4,000 patients in 2014. Globally, the incidence is rated between 1 to 2 patients per 3,000 to 54,000 patients. I've seen also the other country that has done some reporting is Ethiopia, where they report about 62%. When it comes to East Africa and Southern Africa, we still have a challenge in terms of data reporting. So we have a gap in terms of knowing how big this problem is, yet literally everyone in Uganda has experienced this problem in the operating theater. So I think the problem is much bigger than we see. How does this problem happen in our operating theaters? Half the time, we are supposed to review our patients and we do a pre-anesthetic check to see the history of the patient, the physical status of the patient, but also the anatomy of the patient. So in emergency situations, patients who are naturally very short with truncal shortness or shortness of their chest and the back are very much at risk, especially in emergency situations, because half the time we are rushing to save the baby or save the mother, and we fail to recognize that this kind of size of person will not take the normal dose. So as we give the drug, sometimes we end up giving a very, very big volume, which should have not given for that kind of patient. We're supposed to dose revise, and hence one of the reasons we end up getting short patients being one of them is at risk. I mean, getting the short patients at risk is because of the stature. The other issue is also during emergencies, we are under pressure to give the drug, and half the time we just give it as a bolus. And most patients that come in emergencies have a fluid deficit. So half the time you'll have a decreased volume of distribution. When you give this drug very fast, the drug relative to the spinal cerebral fluid will look much higher than before, and it will easily rise very fast to areas that we don't expect. And then there are times when you get emergency mothers that are having contractions, mothers that are very obese, mothers that have a big gravidity, multiple pregnancy, polyhydramnios. These have relatively increased intrathoracic pressure. So if they get a contraction, there is cephalad spread of the CSF. So every time there's cephalad spread of the CSF and we're supposed to give a spine, we're supposed to allow the mother's contraction calm down before we give the drug. So if you give concurrently the drug when there is cephalad spread of the drug during a contraction, you're going to have unexpected sudden blockade of the heart. And then sometimes we've done a spinal and the spine has not taken very well. So after 15 minutes, we choose to top up that spinal. So inadvertently, sometimes the drug is already seated there as a volume. And then when you top up the same volume, you'll end up creating a bigger volume relative to the cerebrospinal fluid. So that can also result into a high spinal. And then sometimes we are good at using large volumes relatively without actually looking at the patient. Some people have it in their mind, I should use 12.5, maximum 15. But sometimes this large volume, which normally works for other patients, may not be good enough for the same patient. So it's always good to recognize that every patient comes with the unique characteristics. Then at times we've given the right dose to the right patient, but when the patients lie down, our beds are ergonomically poor. The head is lying down, so inadvertently you end up getting a drug spreading faster to the areas that are supposed to prevent. And sometimes we don't even have pillows to wedge these patients. So with the right volume, with the wrong bed, you can actually end up spreading further. And also this happens in recovery units. In recovery, we are supposed to have beds that can be able to rise up within 20 degrees up at least to maximum 30. So sometimes we just have a flat bed, and there are patients who have poor absorption of the cerebrospinal fluid drugs, you'll end up getting even a high spinal in recovery if your bed is a risky bed. In management, when we have this incidence, first and foremost, is to recognize it, because the biggest challenge is when people fail to recognize that we've had a high spinal. But if you're able to recognize, there's most likely that patient is going to survive. So when you recognize you have a high spinal, please screen for help. Let the surgical team know you are in a crisis, you have an anesthetic accident that has happened. Try as much as possible to reassure the patient, because those patients are fully awake and they understand what is going on, but they need to be reassured because they feel the impending death. Because you've blocked their heart, they can't breathe and their hands are getting paralyzed. So they can really see what's going on, but they can also feel helpless at that point. So reassure them, tell them what has happened, but tell them you are doing everything possible to make sure that everything improves. Immediately, because you've stopped the heart from, you're paralyzing the heart because of the sympathetic blockade, make sure the patient has additional oxygen, because if you don't do that, this patient is at risk of getting stagnant hypoxia. They have the blood, but the pump that's supposed to be beating their blood is being blocked or being anesthetized. So they are going to have hypoxia straight away. So give oxygen at that point. Try and slightly raise the head so that there is no further spread of the drug beyond T1, which might end up in the brain, which will be a total spinal. So immediately raise the head of the bed. And then because of the hypotension that ensues, you're going to have also poor cardiac output. So straight away give boluses of fluids and immediately start giving vasopressors. So drugs that build up that pressure so that you can have a good vessel return and the heart can continue feeding in diastole, and then hence you'll maintain a cardiac output. In most instances, because you blocked T1 and T4, there's going to be bad bradycardias, or the heart is going to slow down completely. And so you may need adrenaline to improve its rate, but also improve its force of contraction. Ephedrine is very, very good in doing both of these things. It will build up the pressure and also the heart rate, but not so strong. And you may also need doses of atropine. Atropine is very good, but it's not as potent as adrenaline in managing bradycardias that are not so good. And in some instances, people have done atropine, adrenaline, and the heart is still very bradycardic. Then you may use a drug called isoprenaline. One of the drugs you should avoid is phenylephrine. It is good at increasing the pressure of the heart, but it will cause reflex bradycardia or decrease in the heart rate. So for these patients, if you give already, when the patients already have a bradycardia and you give phenylephrine, you worsen the outcome. So avoid phenylephrine. The other thing that you need to improve in the patient physiology is to try and limit things that will cause autocaval compression, and this is the gravid uterus. So wedges do not really offer a lot of help. Putting a saline bottle is not going to offer help on the hip or on the right side. So you do a left uterine displacement so that you displace all the abdominal structures that are lying on top of the inferior vena cava, stopping the return of the blood. And those patients will feel relief, and you may respond much faster. Now, because of this situation that is already putting a maternal circulation at risk, there will be poor perfusion through the placental bed to the fetus. So you put the fetus at risk of getting fetal acidosis. And so as soon as possible, request the surgeons when you're stable to do the cesarean section so that you can improve the fetal outcome. In the event that factors have overtaken you and end up with cephalad spread of the drug, that means the drug has gone beyond T1 and has ended up in the patient's brain, and the patient loses consciousness, still the procedure goes that you need to shout for help, let the surgical team know you have a fetal invade. Fetal because potentially this patient has died. Immediately intubate this patient because these patients have no more airway reflex because your brain is shut off. And normally the brain stem is gone, the cranial nerves are gone. So immediately intubate the patient and start mechanical ventilation for the patient or bag mask ventilation if you don't have a big ventilator. Also, these patients will end up having aggressive convulsions. So these convulsions will worsen your hypoxic events in the brain because of no cerebral blood flow. So make sure you use any anticonvulsants that you may have. You may use Valium, you may use midazolam, you may use phenytoin, you may use Keppra, which is levetiracetam, or you may use thiopental. All these at least will stop a lot of anoxic brain injuries. The other thing is immediately if you have intralipid 20%, it's the antidote for local anesthetic toxicity. So offer intralipid within the first 2 to 3 minutes, 20% of the concentration, which looks like Propofol, in either 250 ml bottle or in a 500 ml bottle, and offer 1.5 mils per kg immediately in the first 3 minutes. And after that, you maintain between 10 to 15 mils per every hour. That will start reversing the effects of the local anesthetic so that it works as an antidote. Because of the emergency nature, the mother has lost consciousness, there is no cardiac perfusion, there is no cerebral perfusion. This patient has almost gone into a cardiac arrest situation. So we need immediately to do a perimortem cesarean section as soon as possible. So the patient has to be operated on, and preferably we have to do a midline incision so that we can get the baby out and somehow get at least improved blood flow. Normally, when you take the baby out as soon as possible, you'll have some improvement in terms of circulation where you get about 25% of the uterine blood supply being shunted over to the systemic circular system. So you end up getting more available venous return. And then continuously support the heart because the heart is going to be very, very weak. So you need to maintain good cardiac output by maintaining the heart rate. So you're going to give the vasopressors to improve the volume, but also improve the contractility of the heart. And then also you may maintain the heart rate. So you will have your antibradycardia medication, inotropes, and vasopressors, but also give fluids. So don't stop giving fluids. The other thing, because of the hypoxic brain injury, these patients end up having a lot of cerebral edema. So we are required to give some osmotherapy. And typically it is either going to be 3% hypertonic saline and 100 mils bolus, or 20% mannitol, 100 mils bolus. Or if the patient continues convulsing, you may have to give both as osmotherapy. The other thing also that these patients go through, because you've stopped the heart beating, the brain is not perfusing, there is global anaerobic respiration. So hypoxia builds up, and then there will be a lot of carbon dioxide buildup, and which increases acidosis, which is not very good for your brain. So for these patients, please give 10 to 50 mils of sodium bicarbonate. In the event that you're having struggle with the maintaining of the blood pressure, calcium gluconate or calcium chloride is very, very good in improving the vasomotor tone of this patient and also improving cardiac contractility. When everything is stable, the baby is out, these mothers should be taken to ICU straight away, and please be honest enough to tell them what has happened so that then they can prepare better for these patients. And also during transportation, we've had instances where patients have been, like, for example, referred to my hospital in Kawempe, and because people don't want to transport these patients with them, they end up extubating the patient, which really worsens the hypoxic patient situation, but also increases the risk for aspiration pneumonitis, which is also going to create more problems. So you have a brain that is struggling, and then you have risk for ARDS because someone has aspirated acidic content in the stomach. So please never refer mother extubated. They should be really intubated and maintained with a tube in place, and then maintained oxygenation either by ambu bag or a mechanical ventilator. Then intralipid should be continuously given to the team that receives the patient so that you are able to reverse much of the effects. And if maintained within the first 12 hours, most patients actually come back with full brain function. The inotropes carry on as long as the pressures are still low or the heart is still struggling. When these patients have greatly improved, you only extubate them when they are fully awake and they can follow your commands. Like, for example, you can ask them if they can understand where they are, blink their eyes, ask them to see if they can cough or swallow. Because of the legal premise of this, we need always to communicate the next of kin, what has happened in the theater and what are our plans in terms of trying to save this patient and where are we taking this patient to be. So that at the end of the day, they understand that it was unplanned, accidental happening in theater, but it was not intentional. But also most of the time they will appreciate, and if you need other additional medication, probably they'll participate in trying to pursue some of those things. For purposes of audit, for purposes of legal protection, we need to document everything that has happened and all the team members that have happened in the process of trying to save this life. But also in terms of clinical audit, we talk about what we call the never invent. The never invent are clinical events that have been catastrophic, but could have been preventable because either of a personal mistake or because of systemic errors. And these help the systems to improve. Like, for example, this CME is one of those things that addressing the never invent. If this problem is happening, can we find ways of addressing the knowledge gap, the skills training? So the never invent has to be part of the auditing. Saying all this is good, but what is the way forward? In order to be able to prevent these things happening, we need, as caregivers, anesthetic officers, anesthetic caregivers, to be able to constantly evaluate our knowledge, our skill set and experience. And we need to attend things like CMEs training so that we can continuously update ourselves. In the event that you have a difficult patient, please feel free to always call a senior colleague or another colleague at your level and find out how different they can manage this kind of risk. The other thing is, every time we come in the theater, many times we've worked in that theater, already things are being misplaced or displaced or even missing. So always ask yourself before you start the case, if I was on this table as a patient, and I got a high spine, am I able to survive or not? If your answer is no, then it is your job to start preparing all the drugs, all the equipment, checking on the bed, but also evaluating the patient in the event that these things go. So basically, it is being preemptive and looking proactive at the same time, because you expect a problem, so you start preparing everything that you need to use in terms of saving this patient. But also we need to be clinically present. Half the time we are in the room, but we're not in the room. You're working, but you're either on WhatsApp or you're answering another question about someone or assisting in another room. So we are working, but we are never clinically present. So for every event, half the time, most people have walked away and that patient arrested because the person had walked away or the person was busy with other things that were not exactly related to the patient. The other thing also is to know that there is a team that we are working with. So when you're in a crisis, please don't keep quiet. Alert them so that they can get to also improve the maternal outcome by being able to work in time. We need always to update our skills, and I've talked about this. Half the time, most of our practitioners either graduated 10 years ago, 20 years ago, and they've stopped working and going for FCMEs. So they are practicing what we call unconscious incompetence. They do not know even that they do not know. And then there are those who just practice what they learned in medical school. So they are conscious but incompetent. They only work what they did. They use what they did in medical schools. And then there are those who know they have a problem, but they are still willing to take the risk. So by and large, every time we've had an event in closing, we should sit down as a team and ask ourselves, how did we come to this? So that means if the surgeon is the lead, the surgeon should oversee the documentation and the discussion or the debrief of the never event happening. How did we come to this? Did we see it coming? Could we have prevented it? What are our lessons from this? Can we have actions drawn out of this that we can work on and improve and prevent further things happening? At this point, I end this session. Thank you so much.
Wow. Thank you very much, Dr. Aggrey. I believe the audience was still captivated. Allow me to invite questions before we go to management of post-dural puncture headache. Yes, Blamba Fred Fry.
Good morning, Dr. Amina. It's good to hear from you and Dr. Aggrey for presenting. Personal experience as an anesthesia provider and also a teacher. One of the things that I've seen cause high total spinal is really when people repeat spinals.
I also want to call on another person, Peter Wanyera.
Yes.
Yeah. Peter is not on. Send out a mic.
Yeah, thank you, doctor. Sometimes when the anesthesia has not taken, the patient sometimes is tilted in a trending back position. Is it a good practice?
Presentation, Dr. Aggrey. I have two things. Number one is
sorry, I see.
Yes.
I hear two submissions. Now you are on. You are on, Peter. You can go on.
He talked, I think, about high trending back position.
Yes.
As part of the anesthesia procedure, once you've given a spinal, you're supposed to assess the spread of the local anesthetic, either by asking the patient to try and first of all assess if there's motor blockade, which is normally the first thing is sensation of pain and temperature. So they'll feel warm, they'll feel tingling in their feet, and depending on the uptake of the drug, they may not be able to lift their drug. And so it means already the drug is working. So at that point, you need to assess if the drug is spreading, cephalad, so that you arrest it before it goes beyond T4. So you're supposed to compare the lower part of the body and upper part of the body, either by using ice or cotton whisk or a pinch or a blunt needle. Now, sometimes you find that the drug has stopped at T6, which is just around the end of the rib cage, and you want it to slightly go up to T4. So that means you do a cephalad drop of the head, which is Trendelenburg. But when you do that, you continuously assess until you think you've reached T4. Half the time we've chosen to do that procedure and then walked away, and in no minute, the patient drug has passed beyond T4. So when you choose to assess with the Trendelenburg, we should stay there. And once the patient's drug has reached T4, then we should elevate back the patient with head up so that we stop the further spread of the drug.
Thank you. Thank you, Dr. Aggrey, for that response. I believe Mike has been answered. I see other questions in the chat. Maybe let me pick one as we go to the hands. Someone is asking on elaboration about use of isoprenaline in case adrenaline and atropine fails to work. And would a NASIC be helpful in managing this hypotension? Maybe you can answer those two, then we can go back to the hands, Dr. Aggrey.
So isoprenaline is not a commonly used drug, especially in our environment, but you can give it either IV or subcutaneous. Typically, it's normally in micrograms. Normally you give, a vial can have 2 milligrams, and you can dilute it and then be able to give smaller balances between 10 to 50 mils every 4 to 6 hours. If you don't have an IV line, you can give it subcutaneous or you can give it IV and assess for the improvement. NASIC, yes, it will definitely improve, but it's going to be very hard to apply a NASIC in the event that you still have a gravid uterus. Because when you have a gravid uterus and apply NASIC, you're going to worsen the autocaval compression. So you'll have a very, very difficult way of improving maternal circulation and cerebral circulation, both the cardiac and cerebral in a high spine and supine event. So the first thing, if you're going to use a NASIC, is to get the baby out and then apply the NASIC. And that would be more as damage control resuscitation. So that would be, yes, applicable, especially if you're going to transport even the patient and you're still struggling with hypertension and you are either short of drugs or you're having refractory hypertension because of the sympathetic blockade.
I see another hand, Dr. Waswa. from St. Joseph's Hospital. Mbabazi, you can go on, Dr. Hamizo.
Thank you so much, Dr. Najem, and thank you so much for the presentation, Dr. Aggrey. Mine is just really about some of the things that I've seen in practice, specifically to do with the gauge of the spinal, whatever needle that we use. I think there is a standard gauge size that usually you tend to use, the anesthesia providers. But I've seen a practice where sometimes when someone struggles with being able to access the space, then they kind of improvise and I think do a combined, you see them passing the spinal needle through, I think, a hypodermic, the cannulas. So either they use a green, which is a 16, So I do not know whether that has an impact or that may influence the risk of being able to be able to get these complications that we're talking about, the high or total spinal in this case, because that's the gauge of the instrument being used or the needle being used have an effect or an influence. Thank you very much.
We can have a question from Mokasa Moses. Mokasa Moses.
Thank you so much. This is Mukasa. Thank you, Aggrey, and others who've supplemented, and I really appreciate. My question to Dr. Aggrey is about total spinal. What is the recovery rate when these mothers are brought to ICU, are referred in a proper way when they are well intubated? 2, I would wish to know whether there is any program with the Ministry of Health to continue sensitizing some of anesthetic providers in the periphery. Most of them, they lack these sessions, and these sessions are so much important. We lose many mothers outside there because of knowledge deficit. I don't know how such can be done. I thank you so much.
There was a question on inotropes, which clarification on which ones can be used. I believe you talked about this, but someone wants clarification. The first question, Dr. Aggrey, was about the gauge of the spinal needle. Which one do you recommend? And in many cases, people have seen in provision. Others use syringe needles to get to access space. Then another question was, in case of failed spinal, when do you decide to repeat? And the last two were, what is the recovery rate in ICU among the patients that you have received, from experience, with high spinal? And the last question was not to, I believe was not to for you, it was to MOH. I'm not sure we have a representative. I'll check among us. Any program from MH for anesthesia providers to try and sensitize and improve knowledge among anesthesia providers as far as this is concerned. So Dr. Aggrey, you got them? We can go on to straight answer.
The first question is about the gauge of needle. The recommended gauge should be a minimum of 25, either a cutting needle or a non-cutting needle. Cutting needle looks like a hypodermic syringe with a slight cut at the tip. And those are the commonest we have in Uganda. They are orange tipped. They are called quinky. Now, with some challenges, sometimes because of poor positioning, one of the challenges is poor position. When patient is uncomfortable or when they have a contracted pelvis, it would be very hard for them to sit upright on the bed. And half the time we are trying to force them to sit on the bed. For the people that have worked in Kawempe or have taught, I've already showed them other methods of trying to make that patient sit better. They can split their legs, and they can also get a pillow to slouch, or you can make them, if you don't have a pillow, you can allow them to completely split their legs and hold onto the surgical bed with their hands pushed forward. The other option is you can actually put a side stool and allow them to put their feet on the stool so that your target is to aim at making the knees higher than the hip. Sometimes also the trick can be you allow them sit on the bed and slightly do a trend and back. And then because they are scared of falling back, they'll slightly lean forward. And that means they open up for you the bag. So with those positions, you're able to use actually your normal gauge 25, and you should be able to go through all the 8 levels or the 8 layers. Now, in the event that you're struggling, you are allowed actually to use a needle through needle technique, which means in standard practice, there are special needles that are provided for that engagement. But in Uganda, we do not have many of those being provided unless you're buying a certain brand. So people have learned to adapt and use the hypodermic needle where you push the needle and then for stabilization or from bending, and then you push another needle through. That actually does not increase the risk for for high spinal, total spinal, because the volume is what will cause you a problem, or the other things like giving during the procedure when someone's having a contraction, or you give it a fast bolus, or you push down the patient very fast, like some of us rest our patients and then end up training back them. That will only contribute to the second topic. If you're not very careful, the bigger the aperture you create on the dura puncture, the risk of getting a post-spinal or post-dural puncture headache increases. So that will cause another problem in itself, but not increasing a first risk. The second question was about when do you say you've had a total, you need to repeat the block. So by definition of the American School of Regional Anesthesia, a failed spinal is only condemned after 15 minutes. So before 15 minutes, you cannot condemn. And then we say a failed one because the drug has not worked completely, or it has worked partially, or it wears off midway the surgery. So if I expect this drug to be 2.5 minutes, 2.5 hours, and within 1 hour the drug has worn off, that still becomes a failed spinal. The last option is you're going to either sedate your patient, which we'll call conscious sedation, with a bit of drug that may have a bit of analgesia like ketamine, midazolam, but also offer 20 mils of 1% lignocaine to the surgeon to a field infiltration so that you can finish the surgery. And the second option is completely convert to a general anesthetic for that patient so that the patient does not feel the discomfort. For any partial, before you start the surgery, or a failed completely, a partial block, you'll need to top up half the volume you had used and make sure that now you change the position of your bevel of the needle so that it is partial because you were sheared to one side. That's why it is a partial block. So this time, make sure that you are in the midline of the back and repeat half of that volume because there is a partial block. For a no block completely, it means the drug did not reach the subarachnoid space. And that means we are free to repeat the normal volume of the repeat. And that should be only after 15 minutes. The third question was about survival. I give a story of one anesthetic officer that called us from Fort Portal, Change Georgia, somewhere around there, and told us, I've had a high spinal, and the patient currently, I think, it has become total spinal now. The patient convulsed. We had a cardiac arrest. We resuscitated. In 2 minutes, we had ROSC. I've intubated the patient. I do not have ICU. I really need your help. What can I do? I told him, I'm very grateful first and foremost that you've really called for help. I asked him, do you have phenytoin or thiopental? He said, I have only thiopental. I said, give that patient thiopental so that you don't have convulsions. But also, you are going to move with that patient all the way from Kenjojo to Kampala, and said, yes, I'm willing to do that. And I'll be calling you midway the journey. Then I told him, give a fluid bolus and then allow phenylephrine, which he only had as phenylephrine, to come with the patient. So I told him, because you have a relative hypotension, he had about, I think, 80-40, give a bolus in that 30 milligrams in the IV fluids and move at least with 2 bottles. If one finishes, you start on another. But also run 100% oxygen, and they were using a number bag and a cylinder in the van. That patient made it Kawempe. The patient was extubated the following. The patient was put on a mechanical ventilation, and the patient was able to wake up the following day. In fact, I discharged those patients from ICU back to Chenjojo. If Dr. Mina, you can recall, there's a time when I was being asked in a meeting, how do you discharge a patient from ICU without HDU and they go back to the community? Because the patient woke up with no neurological deficit. There was no indication for further treatment. We had to de-escalate. The patient woke up fully with full faculties, and she could memorize everything of what had happened, and she was taken back to the village. So that demonstrates that if people are visibly around and manage patients with expectations, they can actually save these lives. But that said, also, we've had many patients lost, and they are lost because of system failures. First of all, the degree of hypoxia the patient has been exposed will determine the outcome. If the person was not around when someone got a cardiac arrest and a cranial arrest, that means you're going to have a prolonged acidotic event. You're going to have hypoxic event both for the heart and for the brain. So that recovery is going to be affected. And even if the patient wakes up, we end up having vegetative states because in terms of neurocranial function, the patient is now vegetative, what we call extended glaucoma scale or GOSE. So the better when you're around to observe these, the better the outcome. But also the earlier you intervene in terms of maintaining blood pressure, heart rate, and also improving cerebral perfusion and preventing cerebral challenges of hypoxia and convulsions, the better the outcome. So yes, these patients survive. Dr. Mugahi has always contacted me to make sure that we continuously teach people around KLMNS in Kampala, but also I've been invited to talk to Lango Group. And then I think I've just made an appointment talk on the 30th of September to the Ankole group. So yes, every region has its concerns and they always reach out to us. And also we have a group of anesthesia providers chaired by Dr. Kintu who respond to emergencies as they happen in Kampala, and through Dr. Bagala, sometimes able to contact us and we're able to respond. Even Dr. Claire is part of it. Myself, Dr. Simwe, there is Masereka and Sorotina. So we are quite a number willing to reach out. And also last year we had to visit Arua, where they're having many spinal challenges, organized by Ministry of Health and UNICEF. So there's a lot of concern and a lot of improvement as compared to the past. Dr. just in 1 minute, let me just answer the doses of inotropes. So
Yes.
inotropes improve cardiac contractility, vasopressors improve vasomotor tone, and these, if you go back to the autonomic nervous system, the alpha drugs will normally be noradrenaline and phenylephrine, and they will improve the preload of the heart or blood return to the heart. But you can't squeeze empty pipes, so you need to give a bolus of fluids. The patients you need to watch out for are the patients that have pulmonary edema risk, preeclamptic and eclamptic patients. So you give judicious fluids and immediately start squeezing the pipes. For those that don't have those risks, you may give a bit of bolus and then start squeezing the pipes as soon as you can. And then also you look out for the cardiac contractility. And the things that can improve cardiac contractility are inotropes. That's adrenaline, the most commonly used, noradrenaline in higher doses, dopamine in higher doses, dobutamine in lower doses. Dobutamine is very, very good because it will increase the heart rate without increasing the, it increases the force of contraction without increasing the heart rate. If you have to use only adrenaline, then you have to keep it to the lower side, especially if someone has had an ischemic event. If you increase the higher doses of adrenaline and start getting the heart rate to run above 100 beats per minute, it means you're increasing the cardiac work. You'll need more oxygen. And half the time, those patients end up getting a repeat ischemic event, and they end up actually having a bad outcome. So you are supposed to use a balance between noradrenaline and adrenaline so that you can improve both the return of the heart and the heart doesn't have to run around, and then improve the contraction of the heart. And the other adjunct you can use, I've told you, is calcium gluconate. Can improve your contractility and also improve your vasomotor tone.
Paul Odong.
Yes, thank you, Doctor. My question to Dr. Aggrey is post-operatively, what are some things that we can do to manage these patients? And is there any advice that you can give for these patients seeking treatment, or rather for the health workers who have to receive these patients at their primary healthcare facilities? Thank you.
Okay, that is noted. Doctor, there was a question on what are the benefits of coughing in patients following if anesthesia is failing to take up, and whether propofol can be used in place of intralipid in case they can't get intralipid, and then can magnesium sulfate be used for convulsions due to high spinal in case they don't have the other anticonvulsants? Yes, I think I can let you take on those ones. And why and for short stature women, in case now we know that they are at risk, what are the different ways we can improvise to prevent this?
First, I'll start with the last question. You can't change people's anatomy. You can only change what you do. What goes wrong is what we've done to the patient, because patients by themselves don't get high spinal. They've come to us. It's us intervening and giving them a drug, and then we are giving them the wrong drug. So my slide, one of the slides says we should be having situation awareness. I'll use a simple example. When you go to the restaurant, there are people who take tea without sugar, but they've taken tea. There are people who prefer taking tea with honey. There are people who take tea with sugar. There are people who like their sugar syrups, and there are people who take sugar just to sweeten it up. So every time you get a patient, individualize your care. Do not standardize in your brain. Dr. Rich has talked about conscious incompetence. You cram, it is 12.5. As the end, it shall be. So one of the things is to look at different patients as different unique individuals. And when you have this drug, ask yourself, what will be the safe dose in this patient? So a person who is, say, for example, a short stature, there is no harm in going between 7.5 to 10 milligrams of bupivacaine, as opposed to 12.5 for most average patients and 15 for extremely tall patients. So you find that your dose should be tailored to this individual patient as opposed to having it written in stone. Other question, I seem to have forgotten it, was about
coughing.
Yes, coughing. Coughing has no role in clinical practice. It is just treating our brains, because the pressure we create from coughing is not enough to push the hyperbaric drug upward. So it is just a psychological feeling that we think we are doing something. The same way if we've done, for example, blocks which are called saddle blocks, given a spinal, the idea of telling someone to squat on the bed has no clinical significance and relevance, because the drug is already hyperbaric. It will descend down to the S1, S2, S3. So by squatting the patient, what are you exactly trying to tell the drug to do, which is already doing? So half the time we are not pharmacologically aware of what these things are. And I think the government has done very well to allow people to go back to school and actually understand the pharmacology, because there are people practicing anesthesia because they were a nurse and were told to go and start learning. But when it comes to understanding the pharmacology of these drugs, they have no knowledge of what they are doing. They're just following by copy and paste. So squatting, coughing, irrelevant. Last question, if I may be reminded.
Yes, thank you very much, Dr. Aggrey, for enlightening us. The other question was, can propofol be used in place of intralipid, and can magnesium...
No, propofol has no role. Propofol has no, it is not the intralipid. The mechanism of action are different. Propofol looks alike, like intralipid, but propofol, what it will help you is just intubation. But also if you're having convulsions, propofol has been noted to actually lower the threshold for convulsions. So propofol will be the wrong drug even to give. So thiopentone is the best drug in these situations, followed at least if you have ketamine. Ketamine does not affect the seizure threshold. And etomidate. So those will be good. Propofol I wouldn't use because it lowers the risk for continuous seizures. Magnesium sulfate, yes, but the caution is magnesium sulfate. Magnesium sulfate is anticonvulsant, antihypotensive. So if you give it, it is going to still lower your blood pressure, which is going to affect your cerebral perfusion. It's also going to affect your cardiac perfusion. So that's the caveat, that if you're going to give it very, very slowly, but at the same time, make sure that you have vasopressors running so that you maintain this cerebral perfusion. If you have nothing and you're against the wall, if you give it, then maintain the patient in a Trendelenburg position so that you have increased perfusion to the brain using gravity. But ideally, it wouldn't be a drug I'd want to use when I have a hypotension state. Unless I have a normotensive state, then it's a good drug because it's anticonvulsant as well.
Okay, thank you. Noted. It should be normotensive. If for hypo, please don't give max sulfate for.
And as well, phenytoin. If you're giving phenytoin, 18 milligrams per kg, do not give as a bolus because you'll definitely lose that patient in 2 minutes. It gives you prolonged hypotension as much as anticonvulsant. So give phenytoin in fluid boluses. And typically give a loading dose, which would be literally 1 gram, but it's 18 milligrams per kg and should be normal saline, as opposed to just giving a bolus. Because some patients have been given a bolus only to die immediately within 2